Hi guys, welcome to my channel. Today I'm going to discuss chronic kidney disease. In this video, we will discuss the classification of the chronic kidney disease and its clinical presentation. Okay, and its clinical presentation, pathophysiology, and treatment. So I request you to watch this video till end. In this way, you can understand this topic. This is a very important topic for your article writing or your examination point of view. So here we are going to start this topic. So first of all, there is a definition of chronic kidney disease, which is defined as abnormalities in kidney structure. So here is the abnormality in the kidney structure or function present for the 3 months or longer. So you can highlight this. It's it's a 3 months or longer with implications for health. Structural abnormalities include albuminuria of more than 30 mg per day, presence of hematuria or red cells cast in urine, sediment, electrolyte, and other abnormalities due to tubular disorders, abnormalities detected by histology, structural abnormalities detected by imaging, or history of kidney transplant. So this is the major definition, and the important point is if kidney disease present for more than 3 months or if there is albuminuria of more than 30 mg per day. So CKD is classified by cause of kidney disease. So you have to know what is the cause, why this kidney disease happen. This may be due to the glomerular filtration rate, GFR category, albuminuria level based on the new recommendation from the kidney disease improving global outcomes guidelines. So this is the KDIGO guidelines which is mentioned in the table 74.1. We will discuss this table in the later page, but here you have to understand the classification of the CKD is based on glomerular filtration rate category and the albuminuria levels. And the important point is the stage 5 CKD, previously referred to as the end stage renal disease. So stage 5 is the end stage renal disease, occurs when the GFR falls below 15 ml per minute. So important thing is when the GFR getting low, like it reaches to the 15 ml, then it leads to the end stage renal disease. Or in patients receiving renal replacement therapy, yeah, like when there is end stage renal disease, then the patient will be receiving the renal replacement therapy. So in this chapter, ESRD refers specifically to the patient who receive chronic dialysis. So there's a two cases when there's a stage 5. It may be the patient has to receive the dialysis, and then the, he or she maybe receive the renal replacement therapy. So this is the important point when the patient GFR level reaches to the stage 5. So the prognosis depends on cause of kidney disease, GFR at time of diagnosis, degree of albuminuria, and presence of other comorbid conditions. So we can prognosis means we can understand the which at which stage the disease present, like kidney disease, what is the cause that kidney disease happen. Maybe the kidney is damaging due to the medication, the kidney is damaging due to the underlying diseases like diabetes mellitus, hypertension, and so you have to understand the what kind of other diseases uh, may be present to that patient. so his kidney is damaging maybe due to the medication, due to the other comorbid conditions, and its GFL levels. So it's the introduction of the chronic kidney disease. In the next, we are discussing the pathophysiology. In the pathophysiology, there are three factors: susceptibility factors, initiation factors, and progression factors. So, susceptibility factors increase the risk for the kidney disease but do not directly cause kidney damage. Susceptibility means maybe they are responsible for causing the kidney disease, but they are not directly involved. So, they may be advanced, reduced kidney mass, and low birth weight ratio or ethnic minority. And dyslipidemia, family history, low income, or education, they may be other factors that causes the kidney damage. And initiation factors are those which are directly result in the kidney damage. So they are directly involved in the kidney damage and are modifiable by drug therapy, or the drug therapy can increase these factors. They include diabetes mellitus. If the patient has a diabetes, then there may be a chance of getting kidney damage to hypertension, glomerulonephritis, polycystic kidney disease, Wagner granulomatosis, and vascular disease. So here you can see this word. I'm going to highlight this word. So here you can see what is the granulomatosis with polyangiitis, previously known as Wagner's granulomatosis, is an extremely rare long-term systemic disorder that involves the okay. So what is the Wagner granulomatosis? Previously known as, now its name as granulomatosis with polyangiitis, or is an extremely rare long-term systemic disorder that involves the formation of granulomas and the inflammation of the blood vessels. So granulomatosis is a formation of the granulomas and inflammation of the blood vessels, which is called the vasculitis. It is a form of the vasculitis that affects the small and the medium-sized vessels in many organs, but most commonly affects the upper respiratory tract, lungs, and the kidneys. So, Wegener granulomatosis may be responsible for the kidney damage. The signs and symptoms of GPA are highly varied and reflect which organs are supplied by the affected blood vessels. Typical signs and symptoms include nosebleed, stuffy nose, and the crustiness of the nasal secretion, inflammation of the uveal layer of the eye, damage to the heart, lungs, and the kidneys can be fatal. So, the GPA or the Wagner granulomatosis is the disorder of the blood vessels, and these blood vessels may be uh, supplying the blood to the kidneys. So, the kidney may also can be affected. So, this is a definition of this is the all about the Wagner granulomatosis. And progression factors which hasten the decline in kidney functions after initiation of the kidney damage. So progression factors are those which enhance the kidney damage. It means, yeah, like initiation factors initiate the kidney damage. Once the kidney has been damaged, then the progressive factors further decline its kidney function. So they include glycemia in diabetics. So if the patient has already diabetic mellitus and there is a glycemic condition like a high glucose condition in diabetes, so there may be a chances of further damaging of the kidney. Hypertension, proteinuria. Proteinuria means there is a high amount of the albumin or the protein in the urine. This may be due to the um, any damage in the nephrons, in the nephron mass, or maybe stones in the in the urinary bladder. So they can cause the proteinuria. Hyperlipidemia, high amount of the lipids content in the blood. Obesity and smoking. So these are the progressive factors, which includes glycemia in diabetes, hypertension, proteinuria, hyperlipidemia, obesity, or smoking. Initiation factor are the certain kind of diseases which initiate the kidney damaging, and progressive factors. Once the kidney has already damaged, these factors enhance the kidney declining function. So most progressive nephropathies share a final common pathway to irreversible renal parenchymal damage and ESRD. So key pathways elements include loss of nephron mass, glomerular capillary hypertension, proteinuria. So they are saying about what kind of mechanisms are involved in the ESRD. The common mechanisms are loss of nephron mass. Loss of nephron mass means there may be any kind of friction in the nephron bodies, and the glomerular capillary hypertension. ग्लोमेरुल्स के जो कैपिलरीज हैं उसके अंदर हाइपरटेंशन मींस वहाँ पे हाई ब्लड प्रेशर की अमाउंट होगी, जिसकी वजह से जो फिल्ट्रेशन का प्रोसेस है वो आपका डिले होता है. फिल्ट्रेशन जो है एबनॉर्मली होती है. दैट्स व्हाई द हाई अमाउंट ऑफ एल्बुमिन और blood cells are going into the urine and proteinuria. So these are the key elements which are the responsible in the renal damage. So the clinical presentation. Clinical presentation means what are the symptoms, right? So what are the symptoms? CKD development and progression are insidious. Like we cannot identify right now. Like they develop progressively. uh, Patient with the stage 1 or 2 CKD usually do not have symptoms. Insidious, like they are वो छुपे हुए इनके symptoms होते हैं. We cannot identify by our eyes. By you have to vigilant about the kidney problem, because if the patient has stage 1 or stage 2, uh, then its symptoms are not visible. So have no symptoms or metabolic derangements seen with stage 3 to 5, such as patient with the stage 1 or 2 CKD usually do not have symptoms or metabolic derangements seen with the stage 3 to 5, such as anemia, secondary hyperthyroidism. Okay. The stage 1 or stage 2 patients has no symptoms. Sometimes no symptoms have been no symptoms have been shown. But for the stage 3 to 5, there are some symptoms like anemia, because the blood loss, the patient can be anemic. Secondary hyperthyroidism, if there is a thyroid problem, if there is a hyperthyroidism, cardiovascular disease, malnutrition, fluid and electrolyte abnormalities that are more common as the kidney function deteriorates. So these are the some symptoms if the patient has stage 3 to 5. So there may be anemia, secondary hyperthyroidism, cardiovascular diseases may happen, malnutrition may happen, and fluid electrolyte abnormalities. So uremic symptoms: fatigue, weakness, shortness of breath, mental confusion, nausea, vomiting, bleeding, anorexia. Uremic symptoms include fatigue, weakness, shortness of breath, mental confusion, nausea, vomiting, bleeding, anorexia. So these are the uremic symptoms. They are generally absent in stage 1 and stage 2, minimal during stage 3 and 4, and common in patients with stage 5 CKD who may also experience itching, cold intolerance, weight gain, and paraffin neuropathies. So these are the uremic symptoms. Uremic symptoms means when the um, uremic symptoms means uh, when the blood cells or the proteins are lost by the urine. So there may be a fatigue, weakness, shortness of breath, mental confusion, nausea, vomiting, bleeding, anorexia. They are mostly absent in stage 1 and 2, minimal during stage 3 and 4, and common in patients with stage 5 who may also experience itching, cold intolerance, weight gain, or papillopathies. Uremic means if there is any problem in the kidney function, so these symptoms may happen. So you have to learn this. The by reaching the stage 3 to 5, there may be anorexia, anemia, hypothyroidism, cardiovascular disease, and other uremic symptoms, which includes the fatigue, weakness, shortness of breath, vomiting, bleeding. These all about the uremic symptoms. So, sign and symptom of HUS can include bloody diarrhea, uremic sign, decreased urination or the blood, decreased urination or the blood in the urine, abdominal pain, vomiting, and occasionally fever, pallor, small unexplained bruises or bleeding from the nose and the mouth, fatigue, irritability, confusion, and seizures. So, um, so what is it's all about uremic signs. So you can see here they are defining the uremic condition, a condition where there is abnormally high levels of the waste products in the blood due to the kidney failure. So this is all about the uremia. Uremia is when there is a high um, it's a condition when there is abnormally high levels of waste products in the blood due to the kidney failure, and very rare require lab tests or imaging. Treatment from the medical professional advice can last several months, caused by the chronic kidney disease. Symptoms include loss of appetite, metallic taste, and confusion. Treatment includes dialysis of the kidney transplant. So this is the uremia. Uremia, mostly we can say the end stage renal damage at this time when the blood coming into the urine, and fatigue, bruises occur. So the bloody diarrhea. This is all about the uremic symptoms. I hope this cleared your it will clear your concept. So what is the sign and symptoms of uremia are foundational to the decision to implement RRT. So if by watching the sign and symptoms, you can make a decision that you implement the renal replacement therapy or not. If the uremic signs are under control, then the patient may be survive without RRT. But if the uremic signs are not under control, then the patient must be referred to the RRT. So this is the important point, which is we are reaching at this point. The treatment. Treatment includes general approach. What is the goal of the treatment? The goal is to delay the progression of CKD, minimizing the development or severity of complications. So if the patient is CKD patient, so your treatment goal is you have to delay its progression, you have to minimize its progression. आपने chronic kidney disease को और ज़्यादा नहीं होने देना, आपने kidney damage को control करना है, kidney damage को बढ़ने नहीं देना, minimizing the development or severity of complications. और इसकी जितनी भी complications हो रही हैं उन सब की को कम से कम करना है, और इसको आप मेडिकेशन के थ्रू कर सकते हो ताकि आपका किडनी का फंक्शन नॉर्मलाइज हो सके. So in this page, see, this is a figure. So this is a figure 74.1 which we have discussed in the previous page. And here they are explaining you the KD code category. Okay. They are explaining the KD code category. This is the KD code category. Okay. The G1, G1, G2, G3A, G3B, G4, and G5. Why we are giving the G1, G2, G3? Because of they are categorized on the basis of the glomerular filtration rate categories. If the GFR rate are greater than or equal to 90, then it's a stage 1. It's mean your kidney function is normal. Your kidney is doing its job efficiently. If the GFR level is high, so you have to learn the basic point that the GFR should be in between 90 and 15. It's a range. If it reaches the if it like greater than 90 or it's up to 90, then the G1 category, or if it's less than 15, then the G5 category. So it's see, it's a normal and stage 1. When then mildly decrease and stage 2, the mildly to moderately decreased, it's mean कि अगर थोड़ी सी बीमारी हुई है या थोड़ी सी एबनॉर्मलिटी आई है किडनी की डिजीज में, किडनी के फंक्शन में, तो वो स्टेज 2 होगा. और अगर माइल्ड से मॉडरेट पे जाएगा तो स्टेज 3. तो दिस इज द रेंज 45 से 59, 30 to 44. Stage 3, G4 में 15, 29. Stage 4 and less than 15, they are reaching to the stage 5. Stage 5 CKD, or you can say the end stage renal disease if requiring dialysis. This page is where this table, you can say, it's very important for your examination point of view, and also someone can ask how many types of how many stages of the chronic kidney disease, and which glomerular filtration, according to which category we can give the stage 5. It's all about the glomerular filtration rate categories, and it's the KDIGO guidelines. So we are going downward. Here they are saying that use the most current consensus guidelines and the best clinical practices for management of CKD. So you have to, first of all, you have to understand the guidelines, then you can go to the clinical practice. If you know about the disease, then you can treat it. If you not know about the disease, then how you can treat it. So this is the point. So you have to take some lab test, and you have to identify the symptoms, the uremic symptoms, and the normal symptoms, and then you can go to the pharmacological therapy. So here we are here. Okay. Here, this is a non-pharmacological therapy. First of all, we go to the non-pharmacological therapy, then we go to the pharmacological therapy. So for the non-pharmacological therapy, restrict the protein to 0.8 gram per kg per day. When your kidney is not doing proper function, so you have to minimize your nutrient content. So your kidney uh, has to do less work. आपने अपनी किडनी के बर्डन को कम करना है. आपने ऐसी फूड्स खानी है जिसमें प्रोटीन की अमाउंट कम हो, ताकि आपकी किडनी को इतना ज़्यादा वर्क ना करना पड़े. आपको वाटर का इंटेक भी कम करना होगा. So here they have mentioned some range that restrict to protein to 0.8 gram per kg per day according to your weight. Check your body weight. The it's okay, it's according to your weight. You have to give 0.8 gram per kg per day. It's mean if the person has 20, just for say the 50 kg weight, then you have to give 0.8 multiplied by 50, and it's all about the whole day protein. So if GFR less than 30 ml per minute, okay, restrict protein to 0.8 gram per kg. But if the GFR is less than 30 ml per minute, if the GFR is less than 30 ml, so you have to take only 0.8 gram protein per kg per day according to your body weight. It's mean if the person has 50 kg, then he has to take 0.8 into 50. So whatever the figure is, you have to take that amount of proteins. Encourage smoking cessation to slow progression of the CKD and reduce the risk of the cardiovascular disease, CVD. So these are the precautionary measurements and the non-pharmacological treatment to prevent the kidney disease progression. And the second one is encourage exercise at least 30 minutes 5 times per week and achievement of a body mass index of 20 to 25 kg per meter square. So you have to take exercise. This will help to improve your kidney function. 30 minutes, and at least 30 minutes you have to take exercise 5 times per week. और BMI आपने दिन और अपना BMI चेक करना which is not more than 20 to 25. Okay, and the next one is pharmacological therapy. Pharmacological therapy depends करती है कि other comorbid condition कौन से हैं. If the patient has diabetes and hypertension with CKD, यानी patient को diabetes भी है, hypertension भी है, chronic kidney disease भी है, तब वो कैसे आप इसको treat करोगे? तो progression of CKD can be limited by optimal control of the hyperglycemia. So अगर पेशेंट डायबिटीज मेलाइटिस का है तो आपको हाइपरग्लाइसेमिक कंडीशंस होने से बचाना है, यानी आपने अपने शुगर लेवल को मेंटेन करना है. एंड हाइपरटेंशन, और आपने अपने ब्लड प्रेशर को भी कंट्रोल करना है. मतलब आपने अपनी डायबिटीज की मेडिकेशन भी प्रॉपरली लेनी है, अपने हाइपरटेंशन को भी मेंटेन करना है. अगर आप अपनी डायबिटीज को मेंटेन, तब आपकी किडनी डैमेज होने से बच सकेगा. So इधर वो मेंशन करेंगे फिगर 74 2 provides an algorithm for management of diabetes in CKD. So we are going to figure 74 doing downward. And the next point they are explaining adequate blood pressure control. फिगर 74 3 में वो आपको ब्लड प्रेशर कंट्रोल का बता रहे हैं. कैन रिड्यूस द रेट ऑफ डिक्लाइन इन GFR albuminarian patient without diabetes. तो अगर पेशेंट को ब्लड प्रेशर है तो आपको अपना ब्लड प्रेशर कंट्रोल करना होगा ताकि आपका GFR कैटेगरी नॉर्मल रहे और आपका एल्बुमिनेरिया की कंडीशन ना हो. So KDIGO guidelines recommend a target blood pressure of 140/90 or less if urine albumin excretion or equivalent is less than 30 mg per 24 hour. यूरिन एल्बुमिन एक्सक्रीशन और इक्विवेलेंट इज लेस देन. अच्छा, अगर आपके यूरिन की में एल्बुमिन की एक्सक्रीशन 30 mg पर 24, मतलब एक दिन में 30 mg से कम है, तो आपका ब्लड प्रेशर 140/90 तक होगा. अगर आप इसके अलावा से आप इंक्रीज कर सकते हो. अगर 30, इन्होंने ये मिनिमम रेंज बताई है, मतलब अगर आपके यूरिन में 30 mg एल्बुमिन आ रहा है तो उस टाइम पर आपका ब्लड प्रेशर 140/90 एक्सेप्टेबल है, ये आपका होना चाहिए. अगर 30 से ज़्यादा मतलब 40 आ रहा है तो 140/90 से कम 130/90 तक ले जाओ. अगर आपका 30 mg से बहुत ज़्यादा आ रहा है तो ब्लड प्रेशर उस लिहाज से मेंटेन रखना होगा. So KDIGO guideline recommend that target blood pressure 140/90 or less if urine albumin excretion is less than 30 mg per 24 hour. और अगर जैसे जैसे एल्बुमिन की अमाउंट बढ़ती जाएगी आपका ब्लड प्रेशर उसके अकॉर्डिंगली मेंटेन किया जाएगा. They are mentioning here, if the albumin excretion is greater than 30 mg, okay, और अगर 30 mg पर 24 आवर इक्विवेलेंट से ज़्यादा है, अगर यूरिन के अंदर एल्बुमिन की अमाउंट 30 mg से ज़्यादा है तो आपका ब्लड प्रेशर इज़ 130/80, तो आपका ब्लड प्रेशर देखो और कम हो गया है. उस टाइम पर आपका ब्लड प्रेशर जो है वो 130/80 है. सो दो कंडीशन उन्होंने बताई हैं. अगर आपने ब्लड प्रेशर को कैसे मेंटेन करना है, आपने यूरिन का सैंपल लेना है, उस सैंपल के अंदर आपने एल्बुमिन की अमाउंट चेक करनी है. अगर एल्बुमिन की अमाउंट 30 mg से कम है, ठीक है, 30 mg या 30 mg से कम है, तो 140/90 ब्लड प्रेशर आपका एक्सेप्टेबल है. अगर उसमें 30 mg से ज़्यादा है एल्बुमिन की अमाउंट, 30 mg है या उससे ज़्यादा है, तो आपका 130/80 एक्सेप्टेबल है. और इस तरह जैसे एल्बुमिन की अमाउंट ज़्यादा होती जाएगी तो आपने अपने ब्लड प्रेशर को मेंटेन करना होगा. तो उसके लिए आपको इनिशिएट करनी होगी कोई ना कोई थेरेपी. सो यू हैव टू टेक angiotensin converting enzyme inhibitor, that are the first line agent, or angiotensin receptor blockers. They are the first line agent for controlling your blood pressure. Or you can add the thiazide diuretics in combination with an ARB if additional reduction in proteinuria is needed. So अगर आपने proteinuria को कम रखना है, मतलब albumin is the प्रोटीन की मांग को कम रखना है, तो आपको ब्लड प्रेशर को मेंटेन करना होगा. ब्लड प्रेशर को मेंटेन करने के लिए आपने चेक करना होगा कि आपके यूरिन के अंदर एल्बुमिन की अमाउंट कितनी है. आपने ब्लड प्रेशर को मेंटेन करने के लिए थेरेपी यूज़ करनी होगी, जो कि आपकी फर्स्ट लाइन थेरेपी होगी, जिसमें आपके आ जाएंगे एसी इनहिबिटर्स और एंजियोटेंसिन 2 रिसेप्टर ब्लॉकर्स, जिसके साथ आप थायराइड डायरेटिक्स भी ऐड कर सकते हो. Non-dihydropyridine calcium channel blockers are generally used as a second-line anti-proteinuria drugs. So, calcium channel blockers (CCB) okay, they are not हो गया. कैल्शियम चैनल ब्लॉकर (CCB) जो हैं वो जनरली सेकेंड लाइन के तौर पर यूज़ होते हैं व्हेन AC और ARBs are contraindicated or not tolerated. So if the patient has chronic cough, so we all know that the AC inhibitors has a side effect that they suffer, the patient may be suffer with the chronic cough. अगर पेशेंट को कफ है और उसको आप इनहिबिटेड AC inhibitors जो हैं वो contraindicated, then you can go switch to the CCB, but this is the second line anti-proteinuric drugs. So AC inhibitor clearance is reduced in CKD. Therefore, treatment should begin with the lowest possible dose, followed by the gradual titration to achieve the target blood pressure, and secondarily so minimize proteinuria. No individual AC inhibitors is superior to another. For more ओके वो कहने कि एसी इनहिबिटर्स की जो क्लियरेंस है वो क्रॉनिक किडनी डिजीज़ में कम हो जाती है, मतलब आपकी बॉडी के अंदर रहती है, आपकी बॉडी से रिलीज उसका कम हो जाता है. तो आपको ट्रीटमेंट शुड बिगिन विद द अब बॉडी से रिलीज कम हो जाएगा, इट्स मीन कि बॉडी के अंदर स्टे करेगी फॉर लॉन्गर पीरियड ऑफ टाइम. मीन्स कि आपको लोएस्ट डोज देनी होगी एसी इनहिबिटर्स की, ताकि अगर वो बॉडी के अंदर रह भी जाती है तो आपका ब्लड प्रेशर एक्स्ट्रा ऑर्डिनरी लो ना आ जाए. ठीक है, जो कि आपका किडनी ठीक से फंक्शन नहीं कर रहा, तो आपकी मेटाबॉलिज्म जो है वो कॉम्प्रोमाइज हुई होती है. तो एसी इनहिबिटर्स मेटाबोलाइज नहीं होगा और इस क्लियरेंस नहीं होगी तो बॉडी के अंदर स्टे करेगी. तो यू हैव टू गिव द लोएस्ट पॉसिबल डोज, और उसको हमें टाइट्रेट इस तरह से करना है कि आपको ताकि ब्लड प्रेशर अचीव हो सके. तो सबके लिए आपको ब्लड प्रोफाइल चेक करते रहनी होगी क्रॉनिक किडनी डिजीज़ पेशेंट की. रेगुलरली उनका ब्लड वर्क होता है जिसमें उनका प्रोटीन यूरिया, उनके सारे जो इम्पोर्टेंट कह लो इलेक्ट्रोलाइट है उनको चेक किया जाता है. उनकी यूरिन के यूरिन के सैंपल्स लिए जाते हैं, उनका ब्लड वर्क होता है, उनके सैंपल्स होते हैं, उनका रेगुलरली ब्लड प्रेशर चेक होता है, उसके अकॉर्डिंगली उनको मेडिकेशन प्रोवाइड की जाती है. So up till now we have discussed the patient with sometimes the laptop may be hang. Okay. 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 The patient with diabetes and hypertension and with the CKD. So how you can manage these? So you have to control your diabetes hyperglycemic condition in kidney. So we will check it in the figure 2 and we have to control our blood pressure. So there is a two guidelines. If the albumin level less than 30, then blood pressure should be 140/90. If the albumin level greater than 30, then blood pressure should be 130/80. And you can give the medication. The first line ACE inhibitors ARB. If the ACE inhibitor, you can add thiazide diuretics with the ARB if to get the desired blood pressure. Or if the first line agent is not available, you can give the second line therapy. Okay. एनीमिया पे जाना है मैंने. ये आ जाएगा anemia. Slowly. This is the anemia of the CKD. So chronic kidney disease make condition. Anemia means low blood. Anemic means हमने अक्सर सुना होगा कि ये पर्सन एनीमिक है, मतलब उसमें ब्लड की वैल्यू कम है, उसमें हीमोग्लोबिन कम है, उसका HP लेवल कम है. सो इन्होंने यहाँ पे डेफिनेशन दी हुई है एनीमिया की कि हीमोग्लोबिन लेस देन 13 ग्राम पर DL फॉर एडल्ट मेल्स एंड लेस देन 12 ग्राम पर DL फॉर एडल्ट फीमेल्स. इट्स मीन अगर आपका HP लेवल 13 ग्राम पर DL से कम है अगर मेल्स के केस में, और अगर 12 ग्राम पर DL से कम है इन फीमेल्स, तो आप एनीमिक कहलाओगे. तो ये उन्होंने सबसे पहले एनीमिया के बारे में आपको बताया है कि एनीमिया की कंडीशन क्या होती है. अच्छा, अब यहाँ पर आपके पास जो फिगर है ये आपको बताती है, वही आप ये बताती है आपको. This is the proposed mechanism of progression of the renal disease. Okay. किस तरह से रीनल डिजीज जो है वो किडनी डैमेज का कॉज बनती है, मतलब रीनल डिजीजेस जो है वो कैसे आपकी पूरी किडनी को डैमेज कर रही होती है. ये मैकेनिज्म है, ये डिफरेंट. ओके. यहाँ पर आपका आ रहा है इनिशियल पैथोजेनिक इंजरी. कोई इनिशियल पैथोजेनिक इंजरी, पैथोजेनिक इंजरी मीन्स कोई ना कोई डिजीज ऑकर हुई होगी. फिर आपकी ग्लोमेरुलर इंजरी होती है. ग्लोमेरुलर इज अ पार्ट वेयर फिल्ट्रेशन occur and the electrolytes imbalance can be occur to the glomerular. So reduced filtration area होता है जिसकी वजह से आपका एल्बुमिन और प्रोटीन्स जो एल्बुमिन प्रोटीन है या ब्लड सेल्स हैं वो आपके यूरिन में आने लग जाते हैं. एडेप्टिव हीमोडायनामिक चेंजेस होती हैं. So there are two steps, diabetes mellitus and atherosclerosis. अगर पेशेंट को डायबिटीज मेलाइटिस है तो फॉर्मेशन ऑफ द एडवांस ग्लाइकेशन एंड प्रोडक्ट्स बनेंगे. ये एंड प्रोडक्ट्स जो हैं वो नीचे जाके आपके प्रोग्रेशन ऑफ द किडनी डिजीज का कॉज बनते हैं. सी प्रोग्रेशन किडनी डिजीज बनते हैं. फिर यहाँ पर आपके आ जाता है रिड्यूस फिल्ट्रेशन एरिया. जब रिड्यूस फिल्ट्रेशन एरिया होता है तो वो आपका अडेप्टिव हीमोडायनामिक चेंजेस होती हैं। अगर हीमोडायनामिक चेंजेस में आपकी क्या जाता है, चूँकि फिल्ट्रेशन कम हो रही है तो इंक्रीज ग्लोमेरुलर ब्लड फ्लो होगा। जब ब्लड फ्लो ज़्यादा होगा तो आपकी ग्लोमेरुलर हाइपरट्रॉफी हो जाएगी, मतलब सेल्स ज़्यादा बनने शुरू हो जाएंगे, एपिथेलियल इंजरी हो जाएगी जिसकी वजह से ब्लड सेल्स आना शुरू हो जाते हैं, एंडोथेलियल इंजरी हो जाएगी जिसकी वजह से प्रोटीन यूरिया हो जाता है, focal detachment of epithelial fluid process, glomerular hyaline deposition, microthrombi, glomerular capillaries occluding in the glomerular capillaries, glomerulosclerosis हो जाएगा. These all, they all are responsible for causing the kidney damage. And और क्या mesangial injury है, mesangial expansion है, microaneurysm formation है, systemic hypertension है. So you can see there is a multiple reasons that are contributing towards the kidney damage. There may be an initial pathogenic, maybe some kind of disease which causes the glomerular injury. This glomerular injury causes the filtration altered. When the filtration altered, then increases the blood flow and causes the capillary pressure, increases the capillary pressure, which causes the endothelial injury, which causes the proteinuria. Then glomerular hypertrophy. These are the formation of the advanced glycation and products. So this is the major mechanism that are involved in the kidney disease. This is the figure 2. In figure 2, they are telling us uh, diabetes and the chronic kidney disease. Now it's the clear. Okay. So आपका target blood pressure less than 140/90 होना चाहिए. If the urine albumin is less than 30, we have discussed it. और अगर albumin level greater than 130 है तो आपका target urine albumin excretion, okay, same thing है. और HbA1c like HbA1c is a molecule which you can see it's necessary to for the identification of the diabetes. So अब हम diabetes को अगर check करते हैं तो हम HbA1c की amount check करते हैं instead of checking the blood glucose. So if it is 7% like 0.07 या 53 millimole per but consider less than 7%. If risk of a hypoglycemia or limited life expectancy. So this is the screen annually of the diabetes with the CKD in patient 5 years from diagnosis of the type 1 diabetes or from diagnosis of the type 2 diabetes mellitus. Metformin, you can continue with the metformin. See, you can give the continue with the metformin. Continue the people with EGFR less than equal to 45 and review in those with the EGFR like this and discontinue the people EGFR less than 30. So if the urine albumin excretion greater than 30 mg per day, then start ACE inhibitor or ARV. We have discussed it with caution. If the EGFR less than 30 or repeat ASR in the 4 to 6 weeks. So guideline for using the ACE inhibitor ARV contraindicated in pregnancy. So ACE inhibitor ensure menopausal females on appropriate contraception if sexually active. Okay. एसी इनहिबिटर एआरबीज कॉन्ट्राइंडिकेटेड इन प्रेगनेंसी. अगर पेशेंट प्रेग्नेंट है तो आप एसी इनहिबिटर एआरबीज की जगह सीसीबी की सेकेंड लाइन एजेंट की तरफ जाएंगे. एंड पेशेंट विद द बायलेटरल रीनल artery stenosis, the patient with the history of the angioedema with AC or ARB. So AC inhibitors ARB are the first line agent, but they're contraindicated in the pregnant woman. And if the patient has bilateral renal artery stenosis, और the patient with the history of the एंजियोएडिमा अगर हुआ हुआ है, प्रेग्नेंट है और स्टेनोसिस है, तो आपने एसी इनहिबिटर भी नहीं देने. चेक eGFR and K level as outlined in table. Hold if the patient has severe vomiting, diarrhea or intravascular volume depletion as a risk of the AKI पेरिनियल. सो आपने तब भी इसको होल्ड कर लेना है अगर पेशेंट को बहुत ज़्यादा वोमिटिंग है, या डायरिया है, या इंट्रावास्कुलर वॉल्यूम डिप्लेशन है. ओके, अगर बीपी टारगेट है, इफ द बीपी इज टारगेट, यस, check BP every 3 months, repeat blood and urine test. और चेक ब्लड और यूरिन टेस्ट. इंक्रीज डोज ऑफ एसी, और अगर बीपी टारगेट पे नहीं है तो आपने एसी इनहिबिटर या ARBs की डोज को इंक्रीज कर देना है, या डायरेटिक्स को ऐड कर देना, लूप डायरेटिक इफ एडिमा. और अगर इंक्रीज डोज ऑफ एसी इनहिबिटर इफ यूरिन एल्बुमिन एक्सक्रीशन लेस देन 30 or reduced, so increase dose of this inhibitor ARB. Add dihydropyridine CCB if required, and other antihypertensives such as beta blockers, alpha blockers to achieve the BP target. If BP is still not in target, then add clonidine, hydrolazine or minoxidil. BP at target 4 to 6 weeks later. अगर नहीं होगा तो आपने CCB ऐड करना है. अगर 4 to 6 weeks बाद हो जाता है तो you have to check after 3 months. So there is a condition about the blood pressure. First two conditions we already have discussed. In this condition, which we should give the first line agency with the ARB. But if the patient is pregnant and renal stenosis or angioedema, then you can switch to other hypertensive drugs. So if the patient BP is on target, then you can continue to check for 3 months. After 3 months, the blood pressure, if it's not in target, then you can give the you can add hazard diuretics. Or if the patient, then if and then again, if it is by adding hazard, it is not if it is not in on the target range, then you can give the CCB and beta blockers or alpha blocker to achieve the blood pressure target. So it's all about managing the CKD in diabetic and the hypertensive patient. So here this is this flowchart explaining treatment of hypertension. Treatment hypertension, kidney disease, non-dialysis, kidney disease without diabetes mellitus, strategy for treatment of hypertension based on the urine albumin excretion and target blood pressure. So according to the albumin level or target blood pressure, we are maintaining the kidney disease. So if the anti is CKD without diabetes mellitus, अगर diabetes mellitus नहीं है, विदाउट डायबिटीज मेलाइटिस, अगर विदाउट डायबिटीज तो आपने यूरिन का एल्बुमिन लेवल चेक करना है. अगर यूरिन एल्बुमिन लेवल ग्रेटर देन 30 है तो एसी और ARB आप बिगिंस कर सकते हो लो डोज एंड इंक्रीज द डोज एट 4 वीक्स इंटरवल. और अगर लेवल इतना नहीं है तो चूज एजेंट बेस्ड ऑन द करंट हाइपरटेंसिव गाइडलाइंस. बीपी टारगेट आपका आ जाएगा 140/90. और अगर बीपी टारगेट अगर एसी ने ARB से भी कंट्रोल होता है, एल्बुमिन लेवल जो है वो आपका 30 से ज़्यादा है, ग्रेटर देन 30 है, देन यू कैन टारगेट 130/80. Alternative to decrease the alternatives decrease the proteinuria of ACE inhibitor have been contraindicated. अगर AC और AB contraindicated, you can go with the CCB, which includes diltiazem, verapamil, non-recommended if the patient on beta blocker may be used in pregnancy. Aldosterone antagonist, spironolactone, eplerenol associated with increased risk of the hyperkalemia. डायरेक्ट इनहिबिटर्स यूज़ कर सकते हो आप, जो कि एलिस्केरन है, नॉट रिकमेंडेड इन कॉम्बिनेशन विद ACRB इफ द EGF are less than 60. Contraindication include pregnancy, bilateral renal artery stenosis, angioedema with ACRB, intravascular fluid depletion. So AC inhibitors ARBs आप यूज़ नहीं कर सकते. They are the contraindicated if the patient is pregnancy or artery stenosis or angioedema. Then you can go for second line agents. Okay. You can give the initiate erythropoietic stimulating agent therapy in all CKD patient with HPs between 9 and 10 अगर anemia है. तो हम anemia देख रहे थे. anemia anemic patient में हमने चेक किया था कि 13 से अगर नीचे है मेल में तो HP level then he is anemic, और अगर 12 से नीचे है HP level then she is anemic. So अगर एनीमिया है तो erythropoietin stimulating agent आप देते हो. CKD with the HPs between 9 and 10 अगर HPs 9 and 10 हो. Target HP is controversial. So iron deficiency is the primary cause of resistance to treatment of anemia with ESA. Iron supplementation is required by most CKD patients to replete the iron stores depleted by ongoing blood loss and increase iron demand. So in CKD patient you are going to give the iron supplementation. Parenteral iron therapy improves response to the ESA therapy and reduces the dose required to achieve maintain target indices. So if the patient has chronic kidney disease, so you have to give the parenteral iron therapy too. In contrast, oral therapy is limited by poor absorption or derivative therapy primarily due to the adverse effects. So you can give the parenteral therapy. IV iron preparations have different pharmacokinetic profile which do not correlate with the pharmacodynamic effect. Adverse effects of IV iron include allergic reactions, hypertension, dizziness, dyspnea, headaches, lower back pain, neuralgia, syncope, and arthritis. Some of these reactions can be minimized by decreasing the dose or rate of infusion. Sodium ferric gluconate, iron sucrose, and ferroxum to have a better safety record than iron dextran products. So, if the patient is anemic due to the chronic kidney disease, then you can give the iron supplements, but you have to watch its adverse effects too. सो आईवी भी देख सकते हो. इसके अलावा वो कह रहे हैं कि आप सबक्यूटेनियस एडमिन भी दे सकते हो. इपोटिन अल्फा, दिस इज द ड्रग which you can give the subcutaneous preferred because IV access is not required and the SC dose that maintains target indices 15 to 30% lower than the IV dose. So आप subcutaneous इपोटिन अल्फा जो है वो ज़्यादा यूज़ होती है rather than the IV, क्योंकि IV से आपको ज़्यादा adverse effects face करने पड़ते हैं, तो you can go for the subcutaneous. Then Devapotin alpha has a longer half-life than apotin alpha and prolonged biological activity. Doses are administered less frequently, starting at once a week by administered IV or SC. ESS are well tolerated. Hypertension is the most common adverse effects. So you can go for the apotin alpha. Evaluation of anemia therapeutic outcomes. So you can evaluate this. Patient should be monitored for potential complications such as hypertension, which should be treated before starting an ESA. So this is all about how to treat the anemia if the patient is chronic kidney disease. You can go for IV, you can go for subcutaneous, but the subcutaneous one is more acceptable. Second, आपका आता है CKD related mineral and the bone disorders. This one, mineral and the bone disorder. अगर आपको chronic kidney disease है तो आपको mineral और bone disorder से को भी face करना पड़ता है. So disorders of the mineral and the bone metabolism are common in the CKD population, include abnormalities in parathyroid hormone, calcium phosphorus, the calcium phosphorus products, vitamin D and bone turnover, as well as soft tissue calcification. Calcium phosphorus balance is mediated through a complex interplay of hormones and their effects on bone, the GIT, kidneys, and parathyroid gland. As kidney disease progresses, renal activation of vitamin D is impaired, which reduces gut absorption of calcium. Low blood calcium concentration stimulates secretion of the PTH. As the renal function declines, serum calcium balance can be maintained only at the expense of increased bone resorption, ultimately resulting in renal osteodystrophy. So this is all the calcium phosphorus balance, which is mediated to the kidney. So to a complex interplay of hormones and they affect the bone in the GIT tract, kidney, and the parathyroid gland. As a kidney progress, renal activation of the vitamin D is impaired. So the renal is responsible for the activation of the vitamin D. अगर आपका किडनी ठीक फंक्शन नहीं कर रहा तो ये वाला प्रोसेस जो है वो डिले हो जाएगा. Which reduces gut absorption of calcium, जिसकी वजह से आपकी calcium की gut which reduces the gut absorption of the calcium. As renal function declines, serum calcium balance can be maintained only at the expense of increased bone resorption, ultimately resulting in renal osteodystrophy. Secondary hyperthyroidism is associated with increased morbidity and mortality and sudden death in hemodialysis patient. So you can go for the dietary phosphorus restriction, dialysis, and parathyroidectomy, a non-pharmacological approach to management of the hyperphosphatemia and CKD MBD. So अगर आपको chronic kidney disease है और CKD भी है तो आपको करोगे आप जाओगे आप किसके साथ जाओगे hyperphosphatemia भी है तो you have to give the dietary phosphorus restriction. You have to give the dietary phosphorus restriction. अगर आपको KD को की गाइडलाइंस पे जाना तो आपने dietary phosphorus restriction करनी है. So here you can see. So up till now we have discussed okay. Up till now we have discussed if the patient has diabetes mellitus and the kidney disease. If the patient has diabetes mellitus, how to treat this? If the patient has if the patient has hypertension, how to treat the disease, and if the patient has the hyperphosphatemia, and how to treat the disease. Then we have discussed about the anemia, and then we have discussed about the anemia and the treatment at the end. So we will discuss in the later video the phosphate. Okay. We will discuss in the later video the guidance of the calcium phosphorus product and the intake parathyroid hormone, and how we can treat the phosphate binding agents for treatment of the hyperphosphatemia in CKD patients. विटामिन डी एजेंट्स को डिस्कस करेंगे एंड हाइपरलिपिडेमिया और कैल्सीमाइटिस. These all about the chronic kidney disease. You can see here calcimimetics, hyperlipidemia. These are the conditions in the chronic kidney disease, and you have to minimize these problems to decrease the progression of the kidney disease. So I hope you like my video. It's all about the chronic kidney disease. If you want to ask other question, you can ask me in the comment. So kindly subscribe my channel and never forget to click on the bell button. Thank you.